Welcome to the Massachusetts School of Law Educational Forum. Thank you for joining us. This program is brought to you by the Massachusetts School of Law and is shown nationwide. The topic for today's show is anorexia and bulimia, acute starvation, endless hospitalizations, obsession, suicide attempts, emotional pain. What am I describing? The life of an anorexic. As you know, Americans are obsessed with thinness, and a segment of society that is largely composed of bright adolescent females is caught in a life of starvation or endless purging. So how does anorexia or bulimia begin? Who is most at risk? Are these diseases fatal? Should advertisements that promote unhealthy, thin images of women be banned? Joining me for this studio discussion is Dr. Allison E. Field, is an assistant professor at the Harvard Medical School and is an associate epidemiologist at Brigham and Women's Hospital in Boston, Massachusetts. Her research focuses on the causes and the consequences of overweight disordered eating among children and adult women. She has written extensively on the topic. Dr. Fields, welcome to the show.
Thank you very much.
Diana Cullum-Dugan is a clinical coordinator of the Nutrition and Weight Management Center at the Boston Medical Center. She is the recipient of a number of honors, awards, and scholarships. Thank you for joining us, Diana.
Thank you.
Dr. Caroline M. Abovian, and how do you say
Abovian.
that? I'll never get it right. You've been a guest with me before, and I butchered it then. She is currently the director of the Nutrition and Weight Management Center and is an associate professor of medicine at Boston University School of Medicine. Welcome to the show.
Thanks, Diane.
And Dr. Stephen Prinz is the medical director at Linden Oaks Hospital in Illinois. He has served as a director of the Eating Disorder Program. Dr. Prinz is a representative of ANAD, is that correct?
That's correct.
And it stands for?
It's anorexia nervosa and associated eating disorders. It's a national organization that promotes support for eating disorders.
And it's a terrific organization. And thank you so much for coming out to do the show.
Thank you.
And I'm Diane Sullivan, your host for the show. Also joining me later on location will be Judy Sargent. She is a survivor of anorexia. She's also the author of The Long Road Back, A Survivor's Guide to Anorexia. Just a wonderful book to read. I don't know if you're familiar with it, panel, but just a delightful young woman. All right, let's begin. Let's talk about anorexia and bulimia. How do you tell when somebody has anorexia?
Well, there's criteria that we look at for anorexia, even though the typical person often doesn't follow the criteria exactly. But usually it's when someone is 15% below ideal body weight and they maintain under that, so they're under 85% ideal body weight. Usually what happens is that the person has a very strong obsessive compulsive quality to their presentation. They spend hours obsessing about food, diet, weight, and this is related to what we call body imagery concerns that the client will have. There's also medical physiological concerns that the patient manifests. What we use for criteria is sort of a biased diagnosis because we say that the patient has to have amenorrhea, and hence a male by that criteria would not be eligible for the diagnosis, which we know is not true.
Sure.
Males actually have a decrease in testosterone levels, but that's how you actually make the diagnosis. Again, we see this in young kids, and they often don't present exactly with 15% ideal body weight at their onset of the anorexia.
And they also deny that their weight is a very serious problem. It's one of the other hallmark symptoms.
Sure. And Judy told me, and she mentions it in her book, to deceive. What she would do is drink 8 to 20 glasses of water before she had to get on a scale. So,
Yeah.
and we all know that water weighs.
Yeah, we've had patients
Weight.
put rocks in their pockets to get on the scales so that they would get a weight gain because they know that, usually we see patients with anorexia or bulimia. We want to see them very frequently, or because if they keep losing weight, we'll have to hospitalize them, and they'll do anything to show us that they're gaining weight.
Unlike myself, when I go for my annual checkup, I even take off my watch because I don't want any extra weight. And they're trying to add it. Anorexia, as I understand it, and I could be wrong on this, but it has among all the psychiatric diseases the highest mortality rate. Is that correct? And if so, why?
That is correct. Yeah, psychiatric illnesses, different illnesses have different mortality rates. Depression is actually pretty high as well. But when we look at anorexia, and again, if we think of it as sort of a psychosocial biochemical illness, we see a lot of associations of other psychiatric illnesses. There's a high association of depression, OCD, anxiety disorders, which adds to the mortality. But also, if we really look at what happens to the physiology of the body, when the body starts to starve itself, often there's electrolyte imbalances, and we know that the heart, for instance, needs a certain amount of potassium to help regulate a steady, healthy electrical rhythm. And these patients at any given time could have an abnormal balance of these important electrolytes for the heart, hence making the pump not work effectively, and then someone actually dying from cardiac arrest. In addition, I mean, there's just numerous medical, physiologic concerns that occur when someone gets into severe anorexia, which puts them at great medical risk for numerous conditions as well, both with the brain, the heart, the bones, fertility issues. So it's a very serious medical illness.
What are some of the other long-term effects for people who develop some type of eating disorder?
Well, the bone loss is dramatic in anorexics, and unfortunately it doesn't look particularly reversible. So you can see osteoporotic fractures in women in their 20s.
Oh, wow.
Which is frightening to think what will they be like when they're in their 60s.
When they're 50 and 60, sure, they fall, they're going to break their bones. Let's talk about bulimia. How is that different than anorexia? What's the difference in the two?
Bulimia is another form of an eating disorder that has some similarities as far as there's still often body imagery concerns. There's still a lot of time spent on obsessing about food, diet, weight, appearance, but it actually involves what we call binge purging. Binging usually involves two components, and one component is actually eating a large portion, a large amount of food at one setting so that one's stomach feels distended, but it also involves a sense of feeling really out of control. So sometimes a person can eat smaller quantities of food but still have that sense of really being out of control.
Right.
Purging is usually some form of undoing behavior of a binge. We most typically think of purging as vomiting, but really undoing behaviors could be using laxatives, diuretics, compulsively exercising. We have diabetic patients that will monkey around with their insulin doses. So it's some form of undoing behavior. And then there's criteria specifically that you have to meet so many episodes in a week's time to make the diagnosis.
Do we have any feel for what percent of the population, or are there a lot of people with these type of eating disorders?
I think you might see a lot of bulimia and not see a lot of it, but there's more of it out there because bulimics can be normal weighted. And they can hide the out of control feeling, closet eaters on the way home stopping at the 7-Eleven and getting 5 candy bars and that type of thing. So they can hide that a little bit more than whereas the anorectic can't, because they usually have the very low body weight.
We think that up to 20% of college kids, mostly females, may be bulimic at any given time.
But not full-blown bulimia. I mean, they engage in the behaviors. And there is a big distinction that when you read in the magazines about these alarming numbers of people who have an eating disorder, there's a bit of mixing going on. I mean, there are people who meet what we call full criteria, and that would be binging and purging at least 2 times a week. And that's maybe 3% of young women. There are many, many more people who binge and purge infrequently. And that number we don't know, it could be as high as 20%.
And with anorexia, percentages, as Diana said, is much lower, and probably we think at any given time, perhaps 1% of the population may have anorexia nervosa.
What are the causes of anorexia? I heard that it typically affects young, bright women. I mean, that's the typical anorexic. What are the causes of anorexia? Is it psychological or is it physical?
Yeah, we think that there's really, again, a biopsychosocial aspect to the illness. It's nice because I had a chance to be with this panel on obesity, but a lot of the same kind of environmental factors and stressors. There's a huge push for thinness in our society, and a very unhealthy push for thinness. Yes. And we start to think that, well, thinness is associated with success, with doing well in sports, and so we get in this unhealthy kind of mindset that a lot of our society puts pressure on. Yeah, what we see, and you're right, you usually see the onset mostly in younger kids. We're actually starting to see onset younger and younger in our society. But usually
Well, isn't there a clear message in this country to young girls that doesn't matter if you're talented, you don't need to be bright, you must be thin. Above all, you need to be thin. Is that the message that we're sending young girls today? I think it is.
I think you're right. We see like a lot of athletes come in, and it's amazing, what happens. Even cheerleaders, that ballet dancers, gymnasts, and what will happen is that they'll come in and they'll say, well, my coach told me I just need to lose a little bit more weight and I'll be able to do my flip a little bit more effectively. And so we're sending very unhealthy messages to our younger people.
I think I think we have a combination of the psychosocial along, again, with the environment, because yes, we have an environment that is teaching us that we need to be thin, and it's put a premium on thinness. And then we have a young society that's growing up and has the same problems as depression as anyone does. And those who are predisposed to become depressed in this society that puts a premium on thinness is manifesting their depression in anorexia and bulimia. And I think that's what's happening.
There's a huge need to fit in during adolescence, and someone else dictates how you should look and how you should behave, and a lot of that, is driven by your peers. You pick it up at home, but the media also does certainly play a role in that.
Should the media promote healthier images?
Well, we've certainly suggested they shouldn't promote severely unhealthy ones. So simply, if what we consider to be severely underweight in the World Health Organization would be a body mass index below 17.5, very low. So for someone who's my height, 5'6", that's weighing less than 100 pounds, that's very thin.
Weighing less than 100 pounds.
And we certainly have suggested at a minimum that the print media should not be using models who are severely underweight. We're not saying use plus size models, at least as a baby step, not using severely underweight models, and that has not been well received.
The media would respond, though, if they put a very thin woman on the cover of a magazine, they'll sell tremendous amounts of the magazine. If they put a normal weighted woman on that magazine, they're going to sell less.
Well, even the plus size models are relatively small. I mean, they're not that large compared to the plus size audience they're addressing. I mean, it's sort of ironic.
The plus size model is probably the average weight woman in the United States.
They're usually a size 12. Plus size models are usually a 12,
average.
maybe a 14. We have magazines in our clinic that have plus size models in them, and I feel like writing the company because to me they're not plus size models.
I mean, it is an interesting comment. I mean, it's making a comment that this makes you very large. Right.
Yeah.
When did America's obsession with thinness begin? And how did it begin?
Some people say it began with Twiggy.
With Twiggy, I was thinking Twiggy.
In the 60s.
Now, how do we get rid of it?
I mean, unfortunately,
any solutions that you can think of?
Unfortunately, I mean, I think the marketing people have been brilliant because they figured you can make women obsessed with their weight to buy products, and now we've extrapolated that to men as well. So the images of men now, I mean, it's really using the exact same technique. I mean, these are images that have been airbrushed and touched up of men with perfectly chiseled chests and six-pack abs, a whole 9 yards. And so I think we're just creating the problem in men as well. I don't know how you get rid of it. I mean, it's gotten to be much more pervasive. And the average American's getting further and further from that look.
Yeah.
I think one of the things that this organization, ANA, does is that, and as we talked about with obesity in our last panel discussion, is that they're really pushing for a national push to help recognize the significance of anorexia and bulimia and the effects that it has on our society, on our kids, on our psychiatric, emotional health. They're actually going down to Washington, D.C. and hitting the lobbyists. They're trying to get purity laws passed so that anorexia is recognized as an illness that needs to be treated as strongly as any other medical illness, and you need to get hospital days to treat this illness. Lots of educational aspects were hitting the schools, and it was in part responsible for trying to pull syrup of Ipecac off the over-the-counter shelves. They're now trying to do a national push to get rid of diet pills as far as selling them to younger kids and teenagers. And so, there needs to be a ton of education and really a national recognition that this is a problem in order to get some help.
I think if you put it this way, it shows you how pervasive it is. I think if you're a young, I know that anorexia and bulimia can occur in males, but it's still relatively rare as compared to what's going on in young women. I think if you're a young woman in this country, especially, and you're bright, intelligent, and you're hoping to have an interesting career, and you go through elementary school, high school, and college, and you don't have any sort of an eating disorder or any inkling of an eating disorder, and you don't obsess about your weight, you are very lucky. And that's a very scary thing to say, but I think it's very true.
And it's very rare.
Yeah.
Panel, what we're going to do now is leave the studio for a few minutes, and I'd like to go to a previously taped segment with Judy Sargent. She is a gal who spent 12 years struggling with anorexia. She overcame it. She's written a wonderful book, and let's take a few moments and go to that interview. So please stay tuned. And to our viewers, I hope you enjoy the segment. Judy, how old were you when you first developed anorexia?
I was 13 when I started losing weight and 15 when I was first hospitalized.
What factors do you believe contributed to your illness?
My parents went through a really difficult divorce, and my father used to kind of pick on me about my weight and tell me that I was fat and I should lose weight. So it started kind of as a self-improvement campaign. And just a simple teenage diet, nothing more than that. But gradually it kind of started to spin out of control, where I was no longer in control of the losing weight, and the only way I was happy was to watch the numbers go further and further down on the scale.
Tell us about your journey in and out of anorexia.
It was really difficult day to day, but I would never admit that to anybody at the time. It would start early in the morning, and I'd force myself to go out and run long distances. And I was really exhausted, and I just remember thinking to myself, I'd listen to music as I was going, and I was so tired, and I just had to go, and I had to go further, and I was just constantly thinking about losing weight and burning calories. And I remember thinking to myself, I'm killing myself. I don't want to kill myself, but I can't stop myself. And that was really difficult. And then there was the covering up, the not eating. At the beginning, my mom really didn't notice that much because she was working, and she could come home and I'd say, well, I already ate. And she didn't really notice that. Or I'd say, I'm going to eat later, I'm going out with friends. But gradually that became more and more difficult to cover up. So then there were the tricks to try to cover up not eating, pushing food around the plate, hiding it, slipping it into my napkin or whatever. And then there were a lot of arguments about the food and the not eating, and it was difficult. And then there was just a physical aspect of the anorexia, which was just being just so tired and cold all the time. I was so cold, just like bone chill kind of cold. I could never get warm. I would take long, like hot baths to try to warm up, and my mom bought me a heated water bed and electric blanket, but even then I was never warm. Even like sitting on a hard chair was painful just because my bones kind of dug in, so I could never really be comfortable. Things like that. So it was kind of a tortured day-to-day existence. And then also the obsessions and compulsions. I had a lot of things that just kept going through my mind that I didn't want to go through my mind, but I couldn't stop them, about losing weight, about exercising. So it was really a tortured existence.
Judy, what kind of treatment did you receive?
They used what they called a behavior modification treatment protocol. So if I didn't gain weight, then I had to stay in my room. They took all my clothes away. I had to wear a hospital gown around. They took my books away. I couldn't have any visitors. I couldn't use the telephone. And I just became more and more depressed with that. It wasn't at all motivating for me, and I just kind of dug my heels in further and didn't eat and didn't do what they wanted. And then at the very end, they wanted to send me to long-term treatment. And my mom came in for a conference, and before the conference, I told her, Mom, if you send me to long-term treatment, and I have to go through more of this, I swear I'm going to kill myself. You have to take me home. And I just begged her, and she took me home. And then there were other hospitalizations after that where the real goal was to gain weight, and they make you gain weight really fast, and if you didn't comply, you know, I was tied down to a bed and tube fed. Well, yeah, it achieved the objective. I gained weight. I mean, there was no question about that. But when I got out, I was more desperate than ever. And it was more difficult for me to maintain the weight that I had maintained before that the doctors weren't happy with, which was, I'm 5'3", and it was about 80 pounds. They weren't happy with that, but after I got out of that hospitalization where they forced me to gain weight, I could never maintain above, you know, above 70 pounds. So I went down to about 65.
And in your book, you really show there were a number, you said 26 hospitalizations over a 12-year period. Do you believe that hospitalization is critical at certain stages, or is it totally ineffective?
Well, with the first hospitalization, it was really difficult. I mean, they treated me like I was not eating just to bother them. And they gave, you know, I interpreted the taking the books away, the telephone, things like that as a punishment. And for me, that was not at all motivating. Now, for some people, they will eat or they'll gain weight or whatever just to get out of the hospital, but I don't think that that's the end solution. For the other treatments that kind of focus just mainly on gaining weight, but not on any of the other things that were going on with me, there were a lot of things I think really kind of contributed to the anorexia, which had to do with like my family's difficult divorce that they were going through, with the loss of my brother when I was young, my twin brother. And there were things that were never ever resolved and really never ever looked at. And I think the other thing is that people didn't ever bother to ask, you know, what are your goals? What are your dreams? What are your hopes? I mean, it was like I was just reduced down to being this anorexic individual, you know, bed number, you know, 5721, 17-year-old anorexic. And nobody cared to get to know who I was, you know, the Judy that wanted to go to an Eastern Women's College, the Judy that dreamed of being a medical doctor, the Judy, the violinist, any of those other aspects of me. I would go into the hospitalizations, you know, with a renewed hope of finding something. And I think what I was really hoping when I went into the hospital was that somebody was going to give me that answer. They were going to wave some magic wand over me and they were going to cure me. And it took a long time for me to realize that really that energy had to come from within. I had to want to get better for myself. Not for anybody else, not to please the doctors, not to please my parents, but that had to come from within. Later on, I finally connected with somebody who really was able to help me, who cared to hear my story and how things were for me. And that really made a difference in terms of me trusting him, being able to open up, and actually being able to commit to the therapy and start to do something for myself.
When you weighed 65 pounds or 67 pounds or even 80 pounds and you looked in the mirror, what did you see?
I saw, this is contrary to what most people think, but I actually saw, you know, kind of the skeletal body at 65 pounds. But it still, for me, I think fat became more than just the body weight. I felt fat inside my own body, and nothing more than like 0 pounds was going to be okay for me. I had to watch the numbers keep going down on the scale, and if they didn't go down, then that was like a failure. I think the fat became a metaphor for something larger, which was that I wasn't happy.
What factors do you believe contributed to your recovery?
I think there's a variety of things. I think, first of all, having a family that was really supportive. Not everybody has a supportive family, that's too bad. But my family really stood behind me, most especially my mom.
Right.
And she just refused to give up hope when everybody else had kind of given up. And that was really, I mean, that made all the difference in the world. I think finding a therapist that I was able to connect with, that I felt like we were working together rather than that person blaming me for my illness. That person was working with me to kind of find the solutions and to guide me, but not telling me what to do and helping me to find my own way. And later on, I work with a woman. In the book, I called her Susan. Actually, she has a different name. But she really encouraged me to just kind of look to the truth of myself. and that made a difference. And then I think eventually I realized that a lot of people were going on with their lives. All my friends from high school had graduated from college, they were getting married, they were having children, they were going on with their lives, and my life was just stagnant and kind of behind locked doors. My younger sister had just graduated from college, and I'd always been really competitive, with her. And to see her graduating from college, and here I was, and I hadn't even gotten to that point. And I think that started to motivate me in a different direction. And then the last thing was that some of my friends had actually died from their disorder. I had 3 friends that died. And it never really struck me, even in lying in intensive care when I was 20 years old in a cardiac intensive care unit, that it could happen to me. But I ended up in an intensive care one more time, and they called my father and they said I wasn't going to make it to see 30 years old. And I think then it kind of really struck me, this could happen to me. And I've never been one to give up or to quit, and I've always been a fighter. And really the ultimate challenge is in achieving recovery, not in remaining sick.
Do you consider yourself fully recovered, or do you worry that one day you may relapse into old patterns of behavior?
I really consider myself fully recovered, and I know I could never go back. Thinking back on, the times when the time when I was sick, I just know that I couldn't go back to that kind of misery.
What advice do you have to individuals who are currently struggling with some type of eating disorder?
I would encourage people who are currently suffering from eating disorders to look within and to try to focus on some of those strengths that they have. I mean, people with eating disorders have incredible gifts, and they have a lot of positive energy. And I think the real answer is in learning to channel some of that positive energy into something that's not self-destructive, into something that will really bring them true happiness and inner peace.
What advice do you have also for family and friends of those afflicted with eating disorders?
That's difficult. It depends upon what the situation is. But I would encourage them to basically try to support the person that's struggling, and also to help that person, if they haven't already gotten into treatment, to encourage them to get into professional treatment. Because as much as the family and friends care, they can't be the therapist. And I think once the person is in professional treatment, that the family and friends can rest a little bit better assured that the person is actually getting the help that they need.
Do you feel, as a general proposition, that outpatient therapy is best for most people, or is it so individualized you really can't answer that question?
It's really so individualized, I can't answer that question. For some people, when the weight is such an issue, somebody is so malnourished, I think really inpatient is the way to go. I don't think that people can do that on their own, so it's really individualized.
Discuss the effectiveness, in your opinion, of drugs, prescription drugs, to help people afflicted with eating disorders.
Psychiatric drugs actually can be effective. It depends upon the given situation. With bulimia, there's a lot of evidence to suggest that drugs like the SSRIs, Prozac, Zoloft, can be really effective in helping to cut down the binge frequency. And for them, I think that's really an important part of treatment. But I think the main point that I was really trying to make in the book was there is no magic pill that will cure the eating disorder. First of all, the desire for recovery has to come from within. If it's imposed upon somebody, a family forces somebody into treatment or whatever, you're doing it for somebody else, it's not going to work. And somebody can't give you a magic pill that will make you better. The pills can help. Antidepressants for the depression that somebody's experiencing, anti-anxiety drugs for anxiety to help somebody get through that kind of critical period. But drugs in and of themselves are not the answer.
Judy, what factors do you believe contributed to your recovery?
It was a very gradual process. A lot of times people will write and say, when was that magic moment that you woke up and you realized you were cured? And it didn't happen like that. It was a real day-to-day, everyday struggle. Some days were easier, some days were more difficult. I would slip back and then, gradually pick myself up. But it really is a process, and I would just encourage people not to get frustrated with themselves, but just to focus on that global goal, take it one day at a time, and realize that if they want to achieve that end goal, that they will get there. If recovery is really what you want, then they can make it.
You wrote the book, The Long Road Back, A Survivor's Guide to Anorexia. What influenced you to write the book, and who do you believe might be helped by the book?
The things that really influenced me to write the book were, like, after I graduated from college, I started a website, and a lot of people wrote to me asking questions, and they were the same kinds of questions. They wanted to, what is the answer? How do you go from being so sick to recovery? It was a kind of an effort to answer some of those questions. I felt like I could reach more people writing the book. And it's really intended to help people suffering from anorexia, for their family members, their friends, to just better understand what it's like. There is an appendix at the back that was written by my mother, talking about what it's kind of like for the family member to go through anorexia, and also a couple of really nice poems by my sister. And I think the important thing to remember is it doesn't just affect the person who's suffering from anorexia or bulimia or whatever the disorder is. It really affects the entire family.
How can somebody purchase your book? Can they go to their local bookstore, and will they find a copy available for sale there?
It should be available through all the local bookstores if it's not on the shelf, also through Amazon.com, BarnesandNoble.com.
You began a medical career and you've continued in that medical career. Tell us about that.
I think just trying to make some meaning of what I've been through and hoping that it's not just all in vain. That I went into nursing originally, then I went on for a master's in psychiatric mental health nursing. I worked on an eating disorders project at the University of Michigan. That was a research project looking at trying to find innovative new ways to help people who are suffering from anorexia.
And you're in a doctoral program?
I'm in a doctoral program right now.
And you're going to continue to focus on helping people with eating disorders?
Eating disorders, depression, women's issues, yes.
That is wonderful. Discuss, if you would, America's obsession with thinness and what role that played, if any, in your own struggles with anorexia.
For me, I don't think that really played a big role, but it's really hard to say because I think a lot of those messages are so subtle that people don't even realize that they're receiving them. And I do think it plays a big role in the growing prevalence of anorexia among the young people. It saddens me really to see that since I was sick in the early 1980s, that the incidence of anorexia and bulimia has really, really increased, despite increased public awareness.
Judy, tell us about your life today.
Right now, I am a doctoral student at the University of Michigan, pursuing a doctorate in nursing science. Most specifically, I'm interested in psychiatric nursing research, and I hope to be able to help other people affected with eating disorders, depression, and other anxiety types of disorders. In my spare time, I love to ice skate. I love to get together with friends, play my violin. My violin's back again. That's something that went by the wayside when I was sick. In this past summer, I did something that was totally crazy, but something that I just really wanted to do, which was I competed in a bunch of triathlons with a friend. I guess the moral of that story is that you can kind of do anything that you want to do, and that if you channel your energy into a positive direction, that there can be positive outcomes.
Morgan! Phone! Yeah, Morgan here. Oh, hi. Right now? Okay. The eensy-weensy spider climbed up the water spout. Down came the rain and washed the spider out. Out came the sun and dried up all the rain. And the eensy-weensy spider climbed up the spout again.
I love you, Daddy.
I love you, sweetheart.
Family. Isn't it about time?
What can I say? It's my girl.
From the Church of Jesus Christ of Latter-day Saints.
You know how inquisitive kids are. That's why you store sharp objects in a safe place. Keep medicines out of reach. And if you have a gun, you keep it unloaded and locked away. As concerned members of the television community, we urge you to be just as careful with television. Kids don't always know what they're watching. That's why you should.
Welcome back to the Educational Forum, where we're discussing bulimia and anorexia. Panna, let me ask you this. How does anorexia or bulimia usually begin? What are the early signs? What are the ages of the people when they first get involved with these eating disorders?
Well, it depends. The weight concerns themselves can start at a very early age. Unfortunately, there's very little data telling us about anorexia. It's a very rare disease. As we mentioned, less than 1% of young women have anorexia. And there are no studies that have followed people from when they were well through the development of the disorder.
Right.
So the information we have comes from people who have had anorexia, and you don't quite know when they tell you about things before their anorexia, is that how it was, or is it a misperception that's been sort of distorted by their disorder? We do think of them as being perfectionistic. We do think of them.
Right. I mean, we often see a young population at the onset, as Alison was saying, and what we'll do is, if you look at ideas about weight and body imagery, there's data that shows anywhere from 40 to 60% of kids in grammar school have concerns about their body imagery. So we're starting, very early as sort of an onset of possible eating disorder behavior. What we'll often see with onset, from, and again, this is not necessarily a research basis based on treating patients, and that there'll be some stressor in their life where a child is either teased about their weight, and it will prompt them to start to say, oh, I have to lose weight to fit in. A coach for some athletic team or cheerleading or swimming or something will say you need to be more thin, and it'll start to prompt the behavior to kick in.
And also usually happens around a change in life, like puberty.
13.
Absolutely.
When they're putting on the
So
excess
13 is a great age. I think there's a bimodal peak between 8 and 13, and then again later on. And that later on is the transition between high school and college. So really, it's classically a bimodal peak where anorexia and bulimia will start to occur.
And bulimia tends to occur a little later than anorexia,
Yeah.
where most of those cases with bulimia occur in late adolescence, early adulthood.
In what Carolyn said, it's very interesting because we think in part, at least for female development, when a girl starts to reach puberty and starts to have physiologic developmental changes, breast development, and the hips start to get wider, and that's often prompt for the beginning of an eating disorder, sort of a loss of control of one's body, and you can't do anything about it other than perhaps maybe I could restrict my caloric intake more and try and keep myself more thin.
Well, anorexics use food to control their worlds, don't they, to a degree?
Yes.
I mean, I don't think Judy's story was different than most anorexics in that you're using your weight and food to control your world.
Sometimes that's all they can control.
Right.
And they don't let go of that.
But
Because they
also-
start out with such a need for control, and then the disorder sort of takes in
But
control.
they control it in their own bodies, but they also try to control other people in their lives by cooking for them,
They'll cook very elaborate meals.
buying them food, preparing a full, elaborate, delicious meal and then not eating it, and watching everybody else eat.
And showing what their strong internal willpower is that what it is?
Well, yeah, they have tremendous willpower. By
It
not
is
eating.
phenomenal.
Yeah.
It really is.
This is the type of personality that we'll see as, again, the sort of perfectionistic, the fantastic students. We say that they have cognitive impairment, but a parent will tell me, how can you tell me that my child has cognitive impairment when they're straight A students and they have this anorexia? But really, they're the perfectionistic, they're the children that want to be the best at everything, to please, to be successful.
They're driven.
Right, and so and what makes it very difficult to treat when you think about it is that we need food to live, and yet their mindset is, I want to take away my food. And so I say it's more difficult to treat than like chemical dependency issues, because an alcoholic, you don't need the alcohol to survive. For these anorexic patients, you need to eat to live.
Right, and you
that
can't
they're,
tell them to avoid a situation where alcohol be present or drugs
Right.
be present. I mean, they need
Right.
to deal with it through the rest of their lives.
And that's why it's such a shame for our would-be athletes. A lot of athletes have this problem and they never become as good as they could be up to their potential because they develop an eating disorder and their athletics suffer. A lot of gymnasts, ballet dancers, but even runners, rowers, anyone who has wrestlers in men also, anyone who has to control their weight to do their sport. And a study done at Penn State showed that there was a certain percentage of the population who did athletics that was able to restrict their weight and not develop an eating disorder, but then a certain percentage that ended up having an eating disorder beyond the time that they stopped the sport. And they think that subset of the population tended to be more depressed and to have a genetic basis. So,
What advice do you give to people that you see who have told you or they have an eating disorder? What do you advise in the early stages? What do you do in the later stages?
I think the hardest thing to do, the reason why anorexia and bulimia are so hard to treat is because there's such a tremendous amount of denial. So I think the best advice would be to accept the fact that you have a problem and see a specialist. Go for treatment. So many anorexics and bulimics go for treatment at late stages when there's really not too much that anyone can do.
But who is the specialist? Is it a nutritionist or is it a psychiatrist? Is it a psychologist? Where do they go?
Or they're not getting there. It's the primary care provider that needs to
And the pediatrician, the adolescent medicine
recognize it.
Right.
Right, well, I think I mean, there's lots of different specialists that if someone, and again, this format is very helpful because it educates people, but if someone, for instance, called ANID, they have a national registry of MDs, psychologists, social workers, dietitians that actually have had some experience in training in treating anorexia and bulimia. And in every large city, there's an ANID representative. So one could call ANID and find out who a specialist is. I think what we need to do is we really need to educate some of the key people, including parents, teachers, coaches, about the eating disorder. And I think that's a step, because then if they have some knowledge base of what's going on, hopefully they could pick up and start to recognize some of these characteristics in their students.
I think it's really important to do. I mean, right now I don't think dentists are trained, and certainly, I mean, you get the erosion of dental enamel. Bulimics will get that, and certainly if a dentist sees that, they should be trained that here are people you can call if you think that this patient needs referrals. Here are people who are available. Same with pediatricians, adolescent medicine docs.
It's sort of a sensitive issue, I think, for dentists to bring up bulimia with a patient in the chair, so that's a sensitive issue.
Right.
At that situation. Pediatricians, I think, would be more comfortable, or a primary care physician. So it's maybe even educating the
parents,
educating the
Parents
professionals.
can be a touchy issue as well, though, and the
that's
coaches
true.
the most touchy, because a lot of the coaches are really encouraging it or turning their eyes the other way.
Of course they do. They want success.
Yes, exactly,
They want
and they
success
know
on
that
their
if-
team, they want winners, and they'll do it at all cost.
Right, and they can simply say, I didn't encourage it, but they didn't help. I mean,
Right, they didn't step in and intervene in a positive way.
But it's got to start somewhere. I think I worked on a website for teenage girls on health and nutrition, and I answered email questions from the girls on nutrition, and almost every email question was about weight. I'm 5'2", I weigh 120, I feel fat, what can I do? 5'2" and 120 is normal. It's average, and these are girls who are normal. They're probably very fit, who are trying to lose weight and become unfit and unhealthy.
Because all the models they see on TV
Exactly.
are thin.
Exactly.
Do most people that have eating disorders ultimately get cured, or is it fatal oftentimes, or do people struggle with it for the rest of their lives?
I think it depends on what the eating disorder is.
And the degree. I think there's a good percentage, and correct me if I'm wrong, there's a good percentage of girls who have bulimia, who go through their elementary years, high school years, college, even in their 20s, struggling with the disorder, and only until they get into their 30s do they finally free themselves of the disease. And the reason why they free themselves is because finally there's something else that fills their life, like a family or their career or something. And I don't know what that percent is.
The data out there, and it's interesting, I know, Ellison, we were talking about this a little bit before, but it's how do you really measure success? You know, what is recovery? Is reducing the eating disorder behavior by 50% recovery? If you're looking at it on a degree, on a spectrum, success rates go up. If you actually look at, is someone absolutely free of their obsessive compulsive behavior, free of their body imagery, maintaining what we consider sort of an ideal body weight, not needing to eat mechanically, that they could go based on their physiologic needs, then the percentage rate goes down dramatically. And the few studies that I'm aware of as far as looking at like 5-year follow-up after a patient has been involved in intensive treatment, I'm talking about inpatient treatment, day hospital treatment, seeing a psychiatrist, a psychologist, a dietitian, doing follow-up, that it's about 50% success rate as far as eliminating all the symptoms. So success rate is not really very high, which I think, argues that this is a very complicated, complex psychosocial, biochemical illness that we really don't know how to treat.
It may be like alcoholism, where people should be considered recovering, and that is simply something they have to battle for the rest of their lives.
Right.
I think they probably do. A lot of psychological issues going on.
Right.
Any other personality traits that are associated with either binge eating or anorexia? We say it usually strikes young, very smart, and sometimes affluent women.
Well, the affluence actually is somewhat of a misperception. I mean, the early studies did show that, and it seems to be now, if you're affluent, you get treatment. And the early studies were treatment studies. We now know, in fact, that bulimia is very common in people who are more impoverished and poor societies. We see it in the U.S. It covers with being overweight. We see more overweight in the lower SES population. So that's actually not quite true.
We tend to see with bulimics, and this is overgeneralizing, so because not every bulimic has these traits, but often we'll see more impulsive kind of behavior. So there's a higher association, for instance, with alcoholism, with sometimes manic depressive illness, with sexually acting out kind of behaviors.
And also shoplifting, isn't that true?
Shoplifting is correct also. What we'll see also is that these patients, the bulimic patients, often feel like emotionally just labile, like that they're not in control of their lives. It's true with anorexic patients, but they're more perfectionist, it's structured, you have to be in control. The bulimic person often feels a sense of just being out of control as far as comparing personality structure.
What role, if any, do genes play in one's propensity to become bulimic or anorexic? Is there any evidence?
I think there's evidence that if you look at mothers and daughters and even grandmothers, that the eating disorder has been seen in the family. That's certain. That there's depression and that runs in families, and also
clustering of psychiatric illnesses.
Exactly. So I think genetically there's depression that runs in families, as well as eating disorders as an offshoot of the depression.
So it could be biologically rooted?
Partially. I mean, I don't think it explains all cases, but we do see clustering, and it may manifest itself as anxiety, it may be depression, it may be an eating disorder.
Now, what is causing the increase in men with eating disorders?
I think that we now have, just with all psychiatric illnesses, and the Surgeon General has put an emphasis on mental health, which is, I think, wonderful, because people are starting to get help for issues, but it's becoming one more acceptable to say that you have an eating disorder as a male, even though it's not acceptable to say you have an eating disorder for most people, but we're raising awareness. Men have some different characteristics than women do, and it's interesting. Men usually start their eating disorder behavior at a higher weight than women do. In part, I think that's our societal pressures on females need to be thin, and more of a push on the female body, importance with physical appearance than the male. You could age as a male and have a pot belly and go bald and somewhat be attractive, but for a female that's not as acceptable. Men actually are more preoccupied with their physical appearance from waist up.
Isn't that interesting?
And females from really waist down. If you
Yeah.
so there's a difference in that sense, but a lot of the characteristics are similar too. I mean, there's some of the same physiologic concerns. There's a decrease in testosterone levels. There's testicular atrophy that could occur with men. The obsessive-compulsive component often occurs with men as well. So I mean, a lot of
we
There
used
was
to
some
look for them in
association with homosexuality, or is that?
yes, that's correct. There seems to be a higher association with gay men with having eating disorders than the heterosexual population.
Is that the male that's trying to model the feminine part of the relation?
You know, I really don't know. I don't think anyone, I don't know if...
Yeah, I mean, it seems like the body ideal in the gay male culture is lean and is slightly leaner than the heterosexual male culture. But what you see in men that you don't see in women is this desire to be lean but to be muscular. And part of the problem is when you're looking for eating disorders and you apply the same criteria for women to men, of course the rates look low. I mean, we're not capturing it correctly.
Right.
And now I think one issue that people are starting to realize is that we need to tweak these criteria a bit if we
Right.
want to capture all the cases.
Sure.
You know, there's been some bias that men are afraid to have what's considered a female illness, and so that may actually lower the rates of reporting the illness, even though, again, it's becoming more acceptable. So that's interesting, but they're saying that up to 10% of eating disorders of anorexia and bulimia may actually be males.
And in binge eating disorder, which would be a disorder people binge eat, but they do not engage in any behavior to compensate for that binge eating, it's almost comparable levels of men and women. Slightly more women, but that is the one eating disorder that affects both genders.
I would think it would be the opposite during football season anyway.
Well, you need to feel out of control. I mean, it's really interesting if you ask men and women about eating these large amounts of food. Men will tell you much more often than women they ate these large amounts of food, but then if you, the follow-up question about did you feel out of control, the answer is no, of course not. So then the rates go way down.
Isn't that interesting? Diana, what advice would you give to people struggling with issues surrounding food as to proper diet and nutrition?
People with eating disorders?
Yes.
A lot of the focus around food is not the same that we would do with other people or people who are trying to lose weight, and we really try to pull back a little bit from focusing on food. We require records. We have them keep food diaries so we can get an idea. They can get an idea of what their eating patterns are. But to take someone, especially let's say an overweight person with binge eating disorder, and put them on a very strict, rigid diet really backfires. It doesn't work very well. So targeting the behaviors, I think, with psychology, psychiatry, and then just working with getting some structure to their food patterns, to their meal patterns, maybe healthier foods, focusing on that so much as trying to increase or decrease their intake.
Judy talked about, you know, after endless hospitalizations that were not successful, when the focus no longer became food and gaining weight, but how was your week, what happened in your week, what was wrong with your week, that was much more successful.
Exactly. What worked for you this week? What was positive? What's something you feel really good about this week that you were able to accomplish?
So would part of your advice to our audience be take your emphasis off of foods, find other things that either make you happy or other things to do and not focus so much on the role food plays in your life?
I think some of the focus should be on the food, but not near the extent that it is a lot of the times. I think
that's
focusing on the...
Yeah, I think that's a very hard concept to impart to an anorectic or bulimic, though. Especially
because their whole life focuses on food.
Their whole life focuses on food and their body image.
And now it's a control issue. You're wanting this anorectic to keep these records, and she's relinquishing some control to you by doing that. Or forcing, if you don't have 5 servings of grain every day this week, I'll hospitalize you. And that's, now you're playing this tug of war kind of thing.
And
so
I think that some researchers have suggested to clinicians that when you're talking about an anorexic and a bulimic, you've just got to keep them as healthy as you can through their growing years, through the years in their teens, they're in their 20s, and hopefully when they hit their 30s, they'll find another focus in their life. And that's really sad, but I think that's where
That's
we're
where
at.
it's at. Panel, I'm sorry, I have to shut down the conversation because I'm getting the sign we're out of time. So I want to thank you very much for joining me for the show, which I hope was very helpful to our audience. I know it was for me, and to our viewing audience. Until next time, be well and thanks for joining us.
Here, Kitty.
Before you know it, she talks. Before you know it, she walks. Before you know it, she knows you. Before you know it, she has a heart. Before you know you're pregnant, when your baby's no bigger than a grain of rice. Before she's a twinkle in your eye, that's when you need to take folic acid every day. After that, it's too late to prevent some serious birth defects. Folic acid now, before you know it.
What inspired David to spend a lifetime exploring distant planets?
Star Trek.
What inspired Nicole to bring new life into the world?
The first time I saw St. Elsewhere.
And what inspired Stephen to risk his life for others?
Hill Street Blues.
Television. Who will it inspire next?
Hey, Brianna, what was that math assignment? Hello?
Hi, honey. What are you doing?
Doing homework with my friends. Aren't I supposed to?
Just called to say hi, that's all.
Hi? That's all?
Yep.
Dad, that's so cool.
But hey, coolness runs in our family.
Well, I was thinking that I need my allowance a little early.
What a coincidence. I need someone to clean the garage for me.
Really?
Family.
I'll see you tonight, Dad.
Isn't it about
All right.
time?
I love you.
I love you too, Dad.
From the Church of Jesus Christ of Latter-day Saints.
You know, I was there when Dr. King shared his dream with the world.
I have a dream today.
And I was there when we launched men to the moon.
Liftoff.
I was even there when Mark McGwire broke the home run record. Yep, I've seen a lot in my day. Thanks to television, of course.
Dad, where are you going?
I'm gonna go play a little golf.
Why?
Because it's Saturday, and that's the day that Dad plays golf.
Why?
Because I really like golf.
But why?
Well, good question. Because most of the time I just spend the day chasing a little white ball around the course.
Why?
Well, usually it's because I hit the ball into the rough or out of bounds.
Why?
I don't know. Sometimes I wonder why I even took up this game. Maybe I'll cut back a little.
Why?
Well, for starters, maybe I could spend a few more Saturdays doing something with you.
Hey, Dad.
Huh?
When?
Family. Isn't it about time? From the Church of Jesus Christ of Latter-day Saints.